Welcome to the CDDFT podcast, where we explore key topics in medical education, training and professional development. In this episode, our host Anne sits down with the experienced clinical teaching fellows to discuss everything you need to know about securing a teaching fellow role, developing key teaching strategies and effectively delivering bedside teaching on the wards. Whether you're a resident doctor considering a teaching role or looking to enhance your educational skills, this episode will provide valuable insights and practical advice. Join us as we uncover the realities of being a clinical teaching fellow and gain expert advice on developing your teaching career within the NHS. So, let's get started.
Good morning, everybody, and here we are at our next podcast on the Foundations to Success platform. And today in the studio, I've got with me two current clinical teaching fellows, and also we've got Charlie, who's our current F2 academic, and he's going to explain a little bit about that programme. The reason that we've decided to do this podcast, at this time of year, I do usually get asked quite a lot of questions about life after F2 and some of the options that the guys have got available to them. So one of the things that I do get asked about is, Anne, what's it like to be a teaching fellow? So obviously I've done teaching with the undergrad programme and now I'm working with the foundation programme. But the clinical teaching fellow posts got a slightly different focus. And so it's useful to look at what skills you might pick up, what skills you might use to get the job, what you're going to learn when you're there, and how it's going to help you in your future. So I'm going to hand over to Alistair, who's our current clinical teaching fellow based at Durham, and let him introduce the rest of the podcast.
Yeah, hello, thanks for that, Anne. So I am a generic clinical teaching fellow at Durham, so I teach on sort of all aspects of medicine and surgery, and do a little bit of sim as well. And I'll introduce the topics and then introduce the rest of the people as well. So we're here to talk about being a clinical teaching fellow, both how to become one and what you do when you do become one. And we'll also talk a little bit about teaching on the ward for those that want to just learn a little bit more about teaching or find out a bit more. We've got hopefully a range of different perspectives, and this is mostly going to be a bit of a discussion. But if there are lots of questions from listeners, then we will hopefully come back to try and address those at a later date. So I think the first thing that we plan to talk about is, how do you get a teaching fellow job? I've certainly been asked that by quite a few people. And I know that the route is now popular and medical education is something that is increasing awareness about, and more and more people want to get involved in. So there are lots of different roles, and I suppose the answer to that question depends on what role you're interested in. So perhaps we should first explain the current roles that we all do and how we got them. Charlie, can I hand over to you to tell us a little bit more about your role and how you got it?
Yeah, sure. So I am a current F2 on an academic rotation. So what that means is I got my job through the normal process via applying through Oriel, as you do at the end of medical school. And this was just one of the rotations that I was given. So I've had a normal set of jobs, so just some medicine surgery jobs, so like diabetes, endocrinology, ortho, stroke, GP, and now as just F2, I've come onto my academic rotation. So what that really means is I'm kind of doing a very similar job to some of the teaching fellows. Obviously, it's not a permanent role, so I just sort of help out as and when. I'm not one of the course leads for a specific area, but I just sort of help out developing teaching sessions for various different times. I help out on different days, help out with simulation, help out on exam days and things like that, and just kind of get stuck in whenever I can, really.
Fab. And how have you found that role so far? How has it been getting involved in a team that's already established?
It was a bit interesting at first because you don't really know how I was going to fit in, but I think the biggest thing you learn is just to sort of carve out your own niche for yourself and sort of throw yourself into what is going on when it's available and what you can do at the time. So I'm actually really enjoying it. It's very varied. There's lots of different things to do. There's a lot of different opportunities going on. So I've been really enjoying it as a job so far, definitely.
Do you think it's something that is useful for somebody who maybe they're applying for their foundation jobs now and thinks that they might have an interest in medical education in the future?
I think definitely I've been very lucky to get this. I have always known that I want to do some sort of teaching in the future and want to encompass that role in some way. So I'm really lucky to have this. I'm actually applying to try and be a teaching fellow next year. So
Listen to the podcast and you'll find out exactly how to be a teaching fellow.
Yeah, I'll get all the tips of the trade. So doing this job has given me a lot of experience that I wouldn't have otherwise had. So if you're thinking about doing teaching, or if you think you might want to be a teaching fellow, a job like this in foundation is definitely a very good thing to try and get yourself onto.
Good.
Fab, thanks for that, Charlie. Shannon, maybe you could tell us a little bit more about your role as well.
Yeah, so hi everybody. I'm Shannon. I'm the simulation teaching fellow, so I live here at Bishop Auckland, basically in the Sim Centre. My role's a little bit different to Alistair's, so instead of being situated in the undergraduate team, I'm situated in the postgraduate team. And my day-to-day is sim and sim activities, which is good fun. And I'm involved in the foundation simulations, the nurse preceptorship simulations, whatever sims are going on in the centre, I'm generally roped in and to help out, which is great. And that's I think, a different day-to-day to what the undergraduates and teaching fellows do and get on with. In terms of, do you want to know a little bit about how I got here?
Yes, please.
So like Charlie, I had an academic FT post, not in this trust, in a different trust, and that was a great opportunity and acted as a little bit of a springboard. And I think that's why I ended up in the sim role. So going back to med school, always been involved in teaching, integrated in medical education. Really always, well, I love teaching. It's a chance to kind of teach the doctors of tomorrow. That's my little, I really enjoy it. But so from that, I had the academic F2 role, did a lot of sim within that, and got to do the faculty development course up at South Tees, so got a bit of exposure and a bit of the knowledge behind simulation, why we run sims the way we do, how high fid sim works, how we debrief, why we debrief the way we do. And I think that definitely helped my application for this job and is why I ended up in this team.
I see that's really interesting. I suppose it shows again what Charlie said, the value of getting some experience in teaching before you try and become a teaching fellow. Were there any other things that you did to get experience, or were there any other things that you did to, improve your CV, as it were, in any way, to help you get that job in addition to the academic experience you had?
Yeah, so throughout my time at medical school, always volunteering to be involved in extracurricular teaching activities, whether that was for different societies. I actually had an education outreach job for the University of Leeds, which was probably the most fun job I've ever had. So I used to get to go into schools in widening access areas and deliver healthcare related careers workshops, and that was fantastic. Absolutely loved that role. And so I did that whilst I was intercalating and kind of followed that through the rest of my time at university. And then whilst I was doing my academic F2 post, so during F2 year, I did my PG Cert in medical education. So kind of building upon my intercalation, getting a further grounding of the underpinning learning theories and all of the lovely stuff that kind of underpins why we teach the way we teach. And that, that's definitely helped. And then in this role, I'm, really fortunate. I think one of the perks of being a teaching fellow is that you'll get some funding to do a postgraduate qualification. So because I already had my PG cert, I was able to do my diploma last year, and I'm currently doing my master's.
That's fab. Obviously, you can speak for the sort of simulation side here, but based on the experience that you've had. If somebody hadn't had an academic job and wanted to find out more about simulation, or wanted to learn more and decide whether that kind of a job was going to be right for them, are there any ways of getting involved in that, or are there any ways of learning more about sim?
Yeah, absolutely. So if you foundation doctors, when they come to their sim days, if anybody has any questions, anything they want to know, if they're keen to get involved, I always say take my email address. We're always happy to have people to come along and join us for the day, and just generally observing how sims work, a bit of behind the scenes, what the roles are. And then as that day progresses, I always tend to get them involved and get them in to be a config, get them in to be a patient, so that, sit in debrief, see how the debriefs work. So that's a great way to get experience. There is courses that you can do. So here we have a faculty development course. Other trusts also offer them, and that gives you a chance to learn some kind of the underpin and learning theory behind it and the styles to debrief in, and because it is a little bit different. It's not your conventional teaching method.
I think it's also worth mentioning that recently in the foundation curriculum, they do have self-development days. So if anybody wanted to dip the toe into simulation or being a teaching fellow, if they got in touch with somebody who was currently doing the role, there's no reason why they couldn't shadow them for one of those self-development days. In terms of their career progression, it would give them some experience along the way, and it's not too time consuming then if they use the self-development sign, which I've got to just push that there. One of the good uses of self-development time.
Yeah, I certainly can say that at Durham we've had some people getting involved in certain aspects of teaching, simulation and some of the formal teaching sessions, as well as obviously teaching on the ward and things like that. And I think that's all something that was really good if you're wanting to apply to be a teaching fellow, and it gives you a flavour of what it'd actually be like as well. I think, and perhaps you could explain from your perspective. What sort of questions do you get asked by foundation doctors, and from your perspective of seeing lots of different sides of teaching and the management of teaching as well?
Yeah.
What are teaching fellow providers looking for in terms of people who apply?
I've been involved in sort of shortlisting for teaching fellow posts in the past. And one of the things that we look for when we're looking at the application forms is more than just that generic statement of I'm a good communicator, for example. So most of the trust interviews will be based around trust behaviours. So you'll be asked questions like, can you give me an example of? And it's always good to look at some of those questions and have a real example from your clinical experience. So give me an example of when you've helped a colleague who was struggling. So that might be something like you noticed a colleague who was on the ward, not getting through the jobs. You'd finished your patient list for that day. So you went to help them out and asked if there was any reason they were struggling, that sort of thing. So a good example of how you have demonstrated the trust behaviours, because that makes an application form stick out from somebody who just gives a bland statement of I'm a good communicator, I'm good at teamwork, I'm good at this, I'm good at that. But an example helps that to stand out. So that'll help your application form to stand out from the rest. So that's the first thing. Then once you get to interview, again, it's about what experience have I had that I can bring to the job with examples. And usually you're asked to do a small teaching session. That's one of the things that I have previously listened to on the interview panel. And you'll be marked on things like how relevant it is to the curriculum. So have an idea of the curriculum, even if you don't know it inside out. Again, make it fun and interesting. There's nothing worse than being sat in front of a, dare I say, boring teacher who doesn't engage you, doesn't get you fired up, that type of thing. So how can you make it practical? What sort of things can you ask them to do? Interpret things, talk about clinical reasoning. Why would you make that decision? What would happen next? What would happen next? So I think that's important. And that's one of the things that we would score them on, which is sort of like engagement with the audience. That's quite important. And the other thing is your openness to the fact that there are doctors and nurses within the team. So recognising that we all come from different backgrounds, we all have a different skill set, and use those skills to make the team the strongest that it can be. So if you know that maybe you're not the strongest in one area, but one of your colleagues is, then using their strengths to build a better team is always a good way forward. And I think really enthusiasm for the job comes over. If we asked sort of like, why do you want the job? And one of the answers we got once was, well, I didn't get into this training post and I didn't manage to fill in my application for Australia. So I thought I'd just give this a bash. It's not really going to get you very far. So make it I want to take this year out to explore other opportunities, and teaching is one of them, that sort of thing. And then once you get here, I think, as Charlie said, you can carve out how you develop yourself. I think you need to be aware of what combination of activities you're going to get. So, for example, the teaching fellows here at Darlington and County Durham, they have a full-time post. So they work 1 day a week clinically and the rest is the academic work. Some areas do 50-50. Some areas will let you get a postgrad qualification alongside that, and there may be some funding or all of the funding. So when you're making the application, look to see what other benefits you're going to get along the way. And that'll help you understand and focus where you want to be.
Fun. Thank you very much for that. I think that's that's really interesting to hear it from that point of view. So I'll speak for myself as well about my job. So I'm a generic teaching fellow at Durham, as I said before, and in medical school I've done some simulation teaching, but I think it will depend on what point you are in your sort of foundation or medical school when you're listening to this podcast as to how much time you've got to develop a CV for becoming a teaching fellow. The post is obviously becoming more and more competitive as more and more people want to do it. But I'd done certain things, and then it's sort of, I knew I wanted to do some teaching, but I'd not got an academic foundation job, and I didn't know sort of too many ways to enhance that CV or what it would take. So in F2, I started to try and do a few things to remediate that in the hopes of getting a job. In my first job in F2, I did quite a bit of teaching, and I was fortunate to do that. But I think
was that just ward teaching, Alistair, as it happened?
No. So I was at the Eye Infirmary in Sunderland, and they had medical students there, so I was able to take some time to do that. It was at times required some balancing, because sometimes I need to be a little bit back and forth, but I think there are often opportunities around, particularly opportunities that you could take some self-development time for. And I really think, like you said, Anne, that if you say, I like teaching, I enjoy teaching, and somebody asks you, what teaching have you done, and you can't say very much, then it obviously...
definitely.
Yeah, it doesn't strike you as genuine, does it? Whereas getting the opportunity to do a bit of teaching, to maybe, we do work in teams a lot. I think that is you work in teams in teaching an awful lot. So I think having some experience of working in a team and having some answers ready to say, do you know what, this is why I want to do these things, is also good. I did do the Teach the Teachers course. I don't know if you guys did that, but I think I don't know how that's looked upon, but it gives you it's not as comprehensive as, for example, the PG Cert, but
is it a university based course, or was it in house?
So they I think some deaneries they do like an in-house one,
right?
But the one I did was online.
All right, okay.
And you basically, you paid to do the course, and it gave you some educational theory and things like that. And I suppose in a way that just shows interest in
Yeah,
teaching.
yeah,
And
definitely.
it shows that you're thinking about teaching styles, and it did help me to prepare for the micro teach that I
Yes,
did.
yeah. So yours wasn't boring then, Alistair?
Well, I hope not.
Yeah, what did you do?
So I would say if you're going to do it, teach about something that you're interested in.
Yeah.
I think it's obviously you want to get it to the time limit. You want to
That's
get a
really
range
important,
of
because you
activities.
will be 10 minutes, stop,
Yeah,
and you might just be getting to the juicy bit and you've got to stop.
But you want to convey some enthusiasm, and
Yeah.
the best way to do that is to teach something that you're interested in.
Absolutely.
So yeah, I did an ophthalmology topic as that's my interest, but you just want to try and make it.
What did you do yours on, Shannon?
So I hate PowerPoint.
Right, yeah.
Yay.
I hate death by PowerPoint sessions, and I think that's my tip for the interviews is you've only got a very short amount of time. It's 5, 10, 15 minutes. Don't bore people with a PowerPoint. And if you must, have a basic structure. But I love a tabletop exercise. So I did a tabletop exercise, which was really interactive around oxygen delivery masks and like the different flow rates for oxygen delivery.
Excellent. That's similar to what I did. I did a talk on CPAP when I got my teaching post a few years ago now. And I didn't want to do PowerPoint, so I tried to demonstrate the principles of CPAP using a balloon. So I gave all the panel members a balloon, and they looked at me and was like, "What on earth?" But I was trying to demonstrate the principles of when you first blow the balloon up, it's really hard work, but then that little bit of air that's left, splinting the airways open. So they were like, all right, okay, so you want us to blow in? They were all pink balloons as well, so no blue balloons for knackered lungs. But yeah, the principle is make it interesting and get them to do something.
Yeah, be engaging. Like I remember going in, they're like, "Oh, we don't have a presentation for you," and I was like, "Yeah, no." And the chair was on the other side of the room next to the laptop, so I just picked it up and moved it to the table. I was like, let's do this together.
Yeah, really good. Yeah,
and I think obviously PowerPoint can be a crutch that you can use to look at and to use, but it does show quite a lot of confidence to go without a structure, without words on a screen to go and do.
Yeah.
And I think that that is, you don't need to be a subject expert in absolutely everything to be a teaching fellow, but you do have to have a degree of confidence to stand up in front of medical students and foundation doctors who you don't know on a regular basis and teach. So I think that is really good. So yeah, I suppose perhaps we should move on now. We've been talking a little bit about teaching strategies. So we can separate out teaching on the wards and maybe talk about sort of formal teaching, sim teaching, that kind of thing. In my job as a generic teaching fellow, we teach by a variety of different methods. We come here to Bishop Auckland to do high fidelity simulation, which I'll let Shannon talk about a bit more. We get involved in that, and like you say, different jobs involve different things. So we do some foundation doctor teaching as well as the undergraduate teaching, which is nice. It's nice to have that variety. But we also do a lot of classroom-based teaching, and we do some teaching on the wards, and we do low fidelity simulation as well, which is essentially simulation with a mannequin in one of the education centres without all the technical stuff around, without the ability to change jobs and things like that. And I think that in terms of things that I've learned in this time, in terms of teaching strategies, I've tried as much as possible to be more and more learner focused, and to try and give the students, the learners, the foundation doctors what they want to get out of the session. I think that's particularly important in teaching the wards, in fact, but we can get to that. But I think there is the tendency to get an idea that you want, that you think is really good and really interesting, that doesn't align with the learner's objectives, and it's always sort of more difficult there. And I do think there's a skill that comes with practice to balancing the teaching that you want to do, where you need to you've got a difficult, complicated topic and you need to teach it to the students, and then giving students their some interactivity to do something back. So some of the sessions that we've done over the past couple of years that have gone down really well are mostly those interactive things. Students tend to really like.
Is that like case-based discussion and then clinical decision making? Which route would you go down if this was the result, and that sort of thing? Is that what you mean?
I think there's a certain amount of that. I think students like the learning embedded in in a practical environment. So like you're a doctor, but one session that springs to mind is we did a session where we did kind of an on the board ward round. So
right,
and then students went away with various different things to investigate and prescribe and so on and so forth. Obviously meeting the learning objectives in terms of the prescriptions, but also the cases were embedded in the learning objectives that they needed to know.
Right.
And they actually quite liked that, because what came out of that was the learning objectives from the point of view of the medical school, where they needed to know about these conditions and they needed to know how to prescribe and do all these kind of things. But also there were a lot of kind of practical tips about being a junior doctor and how do you do this stuff and what would your role involve, because there is a lot of hidden curriculum aspects.
I think that's quite important to have a practical aspect to the teaching, because you usually find that if they need to go away and look at scans, x-rays, blood results, and then come back and think, right, okay, what would you do next? It gives them something to remember. So they'll probably look back on the ward round on the board and think, oh yeah, I remember that, we did so and so. Whereas if you'd just done it by PowerPoint, I think it would just be important at that moment and then it fades away. So something that they can refer back to and have an image in the head. I remember when we did that because I remember this particular aspect of it. So I think it's one thing to bear in mind when you're teaching them.
Giving a tangible takeaway. And I definitely think the final point I'll make is that I think it's very easy as a foundation, as a post-foundation doctor, to remember how you were as a final year medical student, but it's much harder to remember how you were as a third year medical student, because it's been years.
Oh, it's been years, Alistair.
But from your perspective, you can't remember potentially where you got to those where you learnt those things. And I think there's the tendency to want to teach students about the things that you've just learnt in foundation. Whereas I think it's really important to adapt your learning to the learners. I think sometimes you've got an instinct that you want to tell third year medical students about something that's very practical and very embedded in the wards. Maybe how to request something, how to do something. A mistake that you've made that's very practical, when what they need to know at that stage is more embedded in structure, and more embedded in this is how to approach a patient and things like that. And so I think it's really important to think about that. And if you go to your interview saying I want to teach this third year medical students and it's inappropriate, then it's something worth bearing in mind that
get to know the curriculum, I would say. Sometimes you do give a focus when we say prepare a 10-minute teaching session on the first year curriculum point so and so. So sometimes you get something very specific, and that's interesting because even though it's quite specific, it can be interpreted many different ways. And I think that's where you'll get the variety of who can think outside the box of how to teach that particular point. So that's always a good way of seeing who can improvise.
And if it is really broad, so I think when we got our job, it was quite broad. It was just third years. So I emailed back being like, oh, have you got a copy of the third year curriculum?
Well done. That would have got you a brownie point. If we were looking, you see, we would have said, oh, she's asked for the curriculum, brownie point.
Fab. Charlie, can I ask you about the teaching that you've done, and has it met your expectations? Is it what you thought it would be? And how have you found it? And what strategies, what things have you learned while you've been part of the teaching team?
So I think I'm still developing my own journey on the way to being a proper teaching fellow. So I'm still maybe a victim of being a death by PowerPoint a little bit. I do enjoy making my topics, my sessions very interactive. So I won't necessarily dictate things, but I'll just sort of go around the room asking every learning point a question, and then we can talk through it as a way of teaching it rather than just sort of me saying X is Y. I say, what do you think about X, Y, Z?
Yeah.
And doing it that way. I also think, as well as teaching the raw science of the stuff, I do enjoy putting in a bit about, okay, right, you're going to be an F1 in a year or so. What do you need to think about the practicalities of getting this done? Okay, maybe we need to fit a cannula. How big does the cannula need to be to get a CT scan or whatever like that? It's just things that you won't have necessarily thought about as a medical student, and that's what I found really helpful as a student. I think that's particularly where we can fit in as teaching fellows and the academic roles is maybe if it's sort of consultant-led teaching, they can do the sort of more nitty-gritty, but we can sort of do that, okay, you're going to be a junior doctor in a bit. So that's what I sort of think is our best.
And I think you can relate to it because that's what you are. So you think, actually, if I'd been taught this, it'd have been so helpful. So the example you gave there with the cannula, it's really important because technically we sort of like in sim, we sort of do 2 wide bore cannulas, but is that really what you need for a CT scan? So it's those little things that you've picked up as a junior doctor that you're finding useful to tell the doctors of tomorrow, as Shannon put it. So I think that's good to bear in mind.
I suppose that the teaching fellow role has a unique sort of scope within the education environment. While consultants can teach about things and can answer very difficult questions about subject-specific areas, and students will certainly ask, difficult questions or unanticipated questions. But you have a sort of a more near peer role, where you know some of the stuff, and it might have genuinely been a long time since some of the consultants have done certain aspects of a foundation doctor job as well. So there's definitely that to offer.
And there is evidence around peer-to-peer teaching that it is a good way to learn because your peers are not that far away from you in terms of the years of development, so they can put themselves in the place of a medical student and think that would have been really useful for me. And I think that is really appreciated by the medical students, that you can think, how would they feel and what would they like to know at that stage?
Yeah, I think it brings it back to what do you actually need to know. So I think, especially when our second years is very science driven, isn't it? And it's kind of the underlying mechanics of physiology. And then when they transition to third year, that's when we start to bring it tight to more clinical context. But it's actually sometimes they get really caught up on that nitty gritty, the ins and outs of that cycle. What does this enzyme do? And it's actually bringing it to, okay, what does this mean in the context of a person, the patient that you're treating? And I think as a teaching fellow, you're able to ground it kind of like, this is what you need to know. This is what you need to be able to do.
And this is how you apply it to the clinical situation, because you can can talk about shock and all the rest of it and on a PowerPoint or however. But then if you're faced with a patient who is in a shocked state, what will they look like? What will they feel like? And those are the things, the tips that you can pick up that you can't necessarily pick up in a book.
Yeah, and I think that in terms of medical students, it's very hard to get into medical school, and many of the students are academic high flyers that do really well. And one thing that I like about the generic job is that you see the students for a long period of time. You develop relationships with the students, so that there are some students who are at the third year level where they are. That transition to learning in a clinical context hasn't really kicked in yet, and they want to know the depth of everything. They want to really know the underlying science behind lots of different things. But of course, when you come into third year, the breadth of the knowledge that you need to know expands a lot. So it's not usually the most effective strategy for learning, and to be able to sort of, for want of a better word, mentor or coach that student by speaking to them and saying, do you know what, your style of learning might have been great up till now, but you probably need to adapt it a little bit to say, to learn the breadth that you're going to need to know for the clinical stuff, and then you can learn more deeply about the topic.
One thing I'll add as well is that I think, Shannon, you watched me do some of my teaching as well. And something you advised me to do, which is I think has helped with my teaching, is adding in learning objectives and things like that at the start of my teaching, which is sounds like quite a simple thing, but I think it really helps you focus on, okay, today what you're going to be doing is learning how to assess a patient or take a history, or we're going to be learning about the examination and things like that. And that really helps, I guess, the students know what they're going to get out of the session and what to focus on. And you also, when you're developing the teaching session, know that it's not going to be too broad or too diffuse or just sort of get lost on a tangent somewhere.
Yeah.
Things don't always go to plan, do they? It's good to have an idea of, right, I need to steer this back to these essential topics, if nothing else. Fab. So I think we've talked a little bit about some key strategies there. Shannon, is there anything just in terms of the debriefing and the sim? Is there anything that you what have you learned? I know you've come into the job knowing some things already, but what have you learned in the job that's helped you?
I think the one thing I've learned is that so much goes on behind the scenes that you do not appreciate as a participant coming to some simulation. You might think that, they've just, before they've started the day, they've went through a file, they've randomly picked some scenarios, they've chucked them together. This is what we're doing today. At least I know that's what my thoughts were as a medical student. And that is not the case. So I think, I am, in terms of this role personally, I've learned so much about kind of leadership management, project management, arranging staffing, logistics. I wouldn't say that's something that I thought was going to be a massive part of the job, but it really is. And you've got to be adaptable. You've got to, I've got this plan. This is how my day is going to go. Okay. That's not how the day is going to go. I need to scribble on my plan. I need to move some roles around. Somebody's got to be excused at this time because they've got this. And so you've got to have that adaptable nature. And I think that applies to whenever you're teaching and whatever situation you're in. In terms of sim itself, every single scenario is so carefully written and is driven by learning objectives. We set up the scenario and we always say at the start, we're not going to increase the challenge point, and the only thing worse than no sim is bad sim. And people get really anxious and worked up about simulation, and if you've had a negative experience before, that really affects how you feel towards sim. And my goal as simulation teaching fellow is I want people to feel comfortable when they come to sim. I want them to know that sim isn't scary and that we're there to support them through their learning, and it is a safe place. And if you make a mistake in the scenario, that's okay. It's not a real patient. Let's learn together, let's grow, let's go forward. Every scenario is really carefully written. Learning objectives are so important in simulation, and that's what actually drives the scenario. And when you go to do your debrief, so it's a very different type of teaching, because it's not didactic, you're not stood at the front, you're not saying, okay, this is what you need to know. Instead, it's the participants, so it's a facilitated debrief. So what I want is my participants to facilitate and construct their own knowledge. And as they're pulling forward the things that have come out of that scenario, in my head, what is coming up on the board is actually my learning objectives, because we have driven that scenario and it's been so carefully written. So when it comes to that bit where after they've given me, what went well, what they found difficult, what the challenges are on the board, I can see my learning objectives. And that's my chance to then take a little bit of steering of the scenario and, take it back from them and drive home the learning objectives. But again, that isn't me stood lecturing at the front. That is them constructing their own knowledge, bringing together, their own clinical experience, what they've experienced on the wards, and together talking and, building knowledge together. And I think that's the difference. And it can feel really uncomfortable the first few times you're doing it, because you kind of stood there and you're trying your best not to talk, and you're giving the ownership to them. And there is some occasions where you might end up having to do like a 5-minute mini teach, and okay, this is actually how this bit works, or this is this protocol, let's just have a quick look at that. But you always bring it back to the learning objectives. And I think when we get asked to write a new sim, let's do asthma. Okay, what does that mean? What do you actually want to get out of that scenario? Is simulation the best way to teach that? And sometimes it isn't, and that's okay. Would that be better suited to a classroom, or if it's something else, okay, how can we actually make this work? So I don't know if I've gone off on a tangent, maybe.
No, I think it's notable to a generic teacher fellow that when you come to sim and you're doing it, it really feels like you're doing like the debriefs. You're giving the students what they want to know, whereas quite often the topics that you have to teach on, they're not set by you, they're not set by the students, they're set by the GMC and the university. And some topics students are less interested in, of course. So you might be lecturing people about it. It might be very difficult to get the engagement, but sim you always get that. That you always get you both sides are involved, aren't they?
Yeah,
Which is
definitely.
nice.
Something I've heard this team mention around here is that you think the best sort of debrief is one where you don't actually have to say anything at all yourself, which is a very alien concept to me as someone who's not done much simulation as a teaching before this job. It's just sort of when you go in, as you think you have to come with a topic prepared and stuff instead of letting this sort of just conversation naturally develop, which is what you're kind of
It
aiming
is
for.
quite a threatening position to be in, though, at the front when you think, well, they're not talking. So I think it's important at the start of sim days, we usually say, you will get out of this as much as you put into it. So use it to talk amongst the team that you're with, dip into other people's experiences and, have you had this experience on the ward? What did you do? How did it go? It's a really powerful way of learning, I think. But again, if anybody's wanting to see behind the scenes, Shannon will be inundated. But come and spend a day, not necessarily at your sim, but come and have a look at anaesthetic sim or a paediatric sim or something like that, so that you can see what goes on behind the scenes, because it is very, very different to what I expected. Yeah.
And it's a funny thing, isn't it? I think it's very different on the other side of the classroom, and when you get up in front of people, you all of a sudden realise it. There is quite a lot of responsibility that comes with it. It is quite challenging, and with sim, I still find it very, very difficult not just to talk and talk and talk when I'm doing the debriefs. So we're all learning.
Yeah,
With that
definitely.
in mind, teaching fellows learning, and obviously you've seen a few teaching fellows. What do you see?
Careful, Alistair.
One or two teaching fellows. What do you see as being sort of common pitfalls? What
Oh, I wasn't.
what
What
do
I
people
thought you
do
were going
well,
to
or
ask
what
me.
do people do?
Yeah, I think people that stick out in my memory as that was a really good year.
Yeah.
Are people that introduce different ways of teaching. They're quite dynamic. They share a lot of knowledge, but deliver it in an interesting, interactive way. I think the other thing is teaching fellows that are inclusive of the whole team and all the team's strengths. So using them appropriately and acknowledging that there's more than just them plus another clinical teaching fellow. Use the nurse's experience, tap into that, and then together it's a stronger delivery of the teaching. So yeah, we've had some brilliant characters through over the years, and we've had a good laugh as well. I think that's important. Don't be too serious, because it is hard work. It's hard work. It is time consuming. So I think an element of laughter along the way, even if you have a bit of a tricky day, you can get over that. It's not clinical where there's a travesty. So have a laugh about it, share each other's experiences, and just enjoy the time away from the pressures of clinical work, which are obviously really hard at the moment for some of the junior doctors. So it is a chance to step away and have a light-hearted team approach to things.
Fab, thank you very much for that. So perhaps now we should pivot on to talking a little bit about teaching on the wards, because there might be some people listening to the podcast who see medical students on the wards, and I've run a couple of sessions with the foundation doctors, and I know this is an area that people worry about. There's perhaps not enough time sometimes to teach on the wards, and perhaps sometimes people don't feel like they've got the prerequisite knowledge or skills to teach medical students, and people often worry about what's involved in their curriculum and things like that. I think maybe we could open this up to a general discussion. when you're teaching on the wards, what kind of things do you do?
I'll always go out of my way to make sure that if there is a student who's looking lost, that someone is actually sort of talking to them and asked if they need some help or anything like that. I think that makes the biggest difference. As from when I remember as a student, if you just go to an office and everyone's looking away from you on purpose and ignoring you, it makes a big difference. If someone just turns around and says, "Hi, do you want to come with me today? What do you want to get done today? Can I help?" Is the biggest thing.
Yeah, I certainly can say that I've had foundation doctors say to me, "Oh, I just don't know what to do with the students," or what have you. And like you say, making that initial introduction, getting the student on board with you, even if that experience turns into almost purely a shadowing one, means that the student is getting more out of that day than arriving and sort of being ignored. And if you do that, and you have contributed to students' learning in a significant way, get in touch with the department or ask the student to get in touch with the department, and we'll provide you with a certificate. So there is some payoff for it, and if you want to be a teaching fellow, then you've got some evidence there, haven't you, that you have done some teaching.
I think one of the things I don't do much ward teaching now in this role, but when I was in undergrad, patients that have lovely signs, clinical signs, this is dull to percussion. What does that mean? What does that sound like? What might the patient look like? Is really important in bridging that knowledge to application to clinical practice. Because they will have the knowledge, but they're not quite sure what that will sound like. So good clinical signs is always a good patient to take them to see.
Yeah, I definitely echo that, but I'd just also say that I know that I've had some foundation doctors talk to me about patients, and we might go to a ward and they say, "Oh, we've got no patients with any signs here." I think it's important to again contextualise the fact that our third year, fourth year, even the final year students, they're not necessarily looking for PACEs patients with, with really unusual signs and things like that. But if you have, a cholecystitis, if you have a pneumonia, and that patient has some clinical signs, no matter how common that might be, it is good for students to get practice doing the common stuff. Because if we always avoid it, then the students will not have the experience with the things that are actually common.
Yeah.
And I also think it's anything to make them feel like they're part of the team, which they are part of the team, aren't they? And I'm thinking back now to as a final year medical student in A&E, where the lovely SHO got me to ring the surgical reg and hand over a patient and do an SBAR. And you know what? At the time, dreaded it, awful. How dare they make me do that? But afterwards, that was such a good experience.
Yeah.
And the best time to do that is as a medical student when you've got a doctor stood next to you who's there for support, than as a F1 on your first day. Do you know what I mean? That was fantastic.
Yeah, that's really good. That's and I think we probably all remember certain times when somebody's taken us under their wing and said, right, you're going to have a little bit more autonomy. You're going to say where we're going to go next with this bleep or what have you. And I think that's really useful. I think you obviously you're meeting a student for the first time and you're wanting to establish some rapport, and I think it's an important part of that. You won't be able to establish rapport with everybody, but I think some things that I would say is, if you're going to give a student feedback, I think that's something that a lot of people worry about, giving students feedback on on the clinical examinations and things like that. I would always preface that by asking the student before you go in, what do you want feedback on, and setting some expectations.
Yeah.
And that way, if it's an absolute disaster, you already know these are the narrow points I'm going to comment on. It is not my responsibility to comment on absolutely everything. Or if it goes incredibly well, you know how to center that feedback, because it can be even more difficult sometimes giving feedback to somebody who's just way above the level and performed better than you expected. And I think, like you say, keeping things appropriate for the learner. I've had similar experiences where people have got me involved in the clinical team, and I remember one, perhaps not the most appropriate, where I was asked as a medical student to speak to a patient's family by junior doctor who had a complaint to make, and I didn't realise that was what's happening before I went in, and obviously it was a bit unpleasant. It was fine, but I'll I remember who that person was. Let's just put it that way. So
so it sticks out in your mind.
Yeah. So it's there is something to do with appropriateness, but in general, thinking back to what you were doing in medical school, were you taking bloods in third year? Yeah, you probably were. Were you doing an arterial blood gas in third year? No, you probably weren't. It was probably more like final year. And using that as a gauge for appropriateness. And students will know what they're sort of supposed to be doing. It doesn't need they don't need to have, a specific patient on a specific week. Getting that volume of experience, that volume of practice is a big part of why students go on the wards. In terms of teaching on the wards, is there anything else that the group wants to share? Any thoughts?
There's one tiny little thing that I think is quite important. So sometimes you will get patients that are like, oh, I'll do it. I love to see the medical students. And that's great, but beware of the ones that can talk for England. And I don't mean that disrespectfully, but sometimes students struggle to control the history taking. And if you've got a patient, when they say, oh, thank you for seeing me today, can I ask what brought you into hospital? And they go, well, in 1976, and you think, oh no. So be aware of the ones that are willing, but maybe not the most focused. And I don't mean that awfully, because it is nice that they volunteer, but it can make the students just run out of time, and then their confidence is like they haven't had a good experience. So be aware of overly keen patients, I would say. And we've all met them, but yeah, not in a timed Mosler situation.
Yeah, I think it's interesting you say that. You've got to frame it, haven't you?
Yeah.
And not for the Mosler practice, but actual general practice.
Yeah.
Great opportunity, because those patients are wonderful.
Yeah,
and being able to reel somebody back in and steer a history is a very valuable skill. So maybe if they've come to you being like, oh, is there any good patients for Mosler practice, they're not the ones you want to direct them to.
Yeah,
but
definitely.
If it's just okay, I want to practice chatting to some patients, take some history.
For the first years and second years, I think it's good to get patients like that, because they're nervous about speaking to patients. But when you've got a narrow time frame and you've got to get through a certain amount of stuff there, so sort of pick your patients wisely is the motto.
And speaking about time, I know time is something that junior doctors are short of, and there are some ways of making sure that this process of teaching students doesn't take a long time. For a start, it is a completely valid experience for students to shadow you and watch what you do, and maybe be involved in certain aspects, but they can't sign their names to things. But that is a valid experience. It's not that nothing is going on if you are doing work. So I think sometimes well-meaning people will say to students, "Oh, you get yourself away," but in a way that you're not giving them the experience that they're signed up for. The other thing is, when you're short of time, there are some techniques that you can use. If you're going on a ward round, say about one patient who might have an interesting, condition or an interesting situation, I'm going to ask you a little bit about that patient later, and then the student will really switch on when you're seeing that patient and might write down some things. You might even ask them, if it's an appropriate level, like final year, to go ahead of the ward round and pre-round on a patient or two. And additionally, you can do things like, you can look at things like the 1 minute preceptor, but if you see, whether you see a patient together with the student or whether the student goes to see the patient who's already been clerked on their own, you can in a very short space of time get the student to tell you the salient points, commit to a diagnosis, and tell you why they think that's the case, and that contracts down, really condenses what is a long process of eliciting all that information, summarizing it and synthesizing it into that final minute. And the student can't do that without going through that full process, and that means that if you're short of time, you've maximized your time and the students' time, and you've respected both, which I think is
Yep.
a good thing. And while we're on the topic, obviously in terms of I've had it said to me by foundation doctors before. Or students, a student has asked me if I can leave early or something like that. I found it an uncomfortable situation. I didn't know what to say, and obviously the answer to that question is it's not your responsibility. You don't need to, you don't need to tell anybody that they can leave early or that they can't leave early. It's not down to you. The student is self-directed and they know their own timetable, so they know what they're there to be doing.
Yeah, and they're adult learners, isn't it? And I think
Yeah.
ultimately sometimes that gets a little bit forgotten, doesn't it?
Absolutely, yeah. And if a senior doctor tells them to leave the ward, or if they've got something they need to be doing, then they can take themselves off it. Yeah, it's absolutely right that we respect students as adult learners, isn't it? Fine. Anything else we want to share on that, or shall we wrap up with the conclusion?
I think wrapping up, maybe. Do you think,
Yeah,
Anne?
yeah.
Mm-hmm.
Any other questions? You want to add anything in?
I suppose I'd just like to give encouragement out there to anybody who does want to take on a teaching fellow role. I found my role to be both interesting and very sort of valuable. I think I've learned a lot of. It's a good opportunity to consolidate your knowledge, isn't it?
Yeah.
But also, I think it's I've learned a lot of sort of more things about me personally, working in a team, sort of delegation, but all sorts of different things you pick up, and also I think the link between teaching students and communicating with the public is quite strong, and I think as you improve those skills, you do find that it helps you clinically. So I'd really encourage anybody that's interested in it to do it. But like you said, Anne, I'd also encourage people to think about the kind of job that they want to do, whether that be a sim fellow, whether that be working 50-50, 30-70. There's a lot of different opportunities around, and I think I've enjoyed the ability to combine a bit of clinical, and I think it's worth giving a lot of thought to what you'll actually want to do for that long period of time that you might be doing that job.
Yep, I agree.
Yeah, I'd echo that. It's worth, it's a great opportunity, and actually it's fantastic working Monday to Friday, normal hours, no night shifts, no on calls. Having your weekends to yourself. I think I love that element of it, and getting a little bit of routine.
And to be fair, it is good because you get a chance to step off the treadmill of training and just take a breather, and those things like weekends and that are important, and recharge your batteries before you set off on your next journey.
Yeah, whatever it may be. And also, like, coming into that, it's really valuable just to think, actually, what do you want to get out of that year? You're going to develop your teaching skills, tick. But also, is there any other qualifications you want to get? Is there any projects you want to work on? What do you want to spend your clinical time in? And, the best part of the sim job, I think, for me, is it's that element to design new sims. It's the creativity. It's, actually driving forward and coming up with new ideas and thinking creatively about things. So it's, think, what actually do I want to get out of that job? What can I give that job? But what can I get myself as well?
Yeah, great stuff. I think hopefully people have found the podcast interesting. So if anybody... Has everybody got anything else to say? We wrap it up. So just if anybody wants to ask more about the Teaching Fellow post, I'm sure that Alistair and Shannon would be willing to ask any questions, or again, you can come and ask the clinical educators for the foundation team. So thank you, Alistair, for pulling this together and for getting us all in the same room at the same time.
That's the biggest challenge, isn't it?
Yeah. So hopefully, if you're listening to this, you found it useful. If there's anything that we have missed out or you'd like to clarify, just let us know. And also, if anybody else would like to be involved in doing a podcast, then obviously just let us know. We'll book the studio and think about some topics, because the facilities are there for you to get involved. So anything else you wanted to mention, Alistair?
No, I think that's great. Thank you very much for coming down, everybody. And I hope that's been useful to people. If you do have any more questions, then you can always email the undergraduate team. You can come down to the Sim Centre at Bishop. You can go to the education centres at Darlington or at Prospect House in Durham, and we're all the team more than happy to answer any questions. We're very friendly, so please do if that's something you want to do.
Thank you very much. Thank you.
Thank you.
Thank you.
Bye bye.